Hello and welcome. I am Dr. Mariam Aziz. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's CMEO briefcase entitled The Pediatric Patient with HIV, Translating Data into Practice. Today's program is supported by an educational grant from Gilead Sciences. I am Dr. Mariam Aziz. I am an associate professor in the Department of Internal Medicine and Pediatrics in the Division of Infectious Disease at Rush University Medical Center in Chicago, Illinois. Our learning objective for today is to integrate best practices for initiating switching antiretroviral therapy in children based on safety and efficacy data. So let's start by meeting Cynthia, a 26-year-old African-American woman who's pregnant with her first child. So Cynthia is a 26-year-old African-American female. Her first prenatal visit was at 24 weeks of gestation. Her opt-out HIV testing was negative, and since then she's had intermittent engagement in prenatal appointments. At 28 weeks, she presents to OB-GYN concerned that her partner has just begun injecting drugs again after a 3-year period of abstinence. Her HIV test is negative. Her partner is tested and is HIV positive. So what this brings up is the concept of repeat HIV testing in the third trimester. Providers should be proactive about assessing the risk of HIV in the third trimester. There's multiple studies that show this, but a recent study in Baltimore found that only 28% of women were retested for HIV despite that high prevalence. And a study that was between 2007 and 2014 of children with perinatal HIV exposure in Florida found that third trimester testing was not performed in a good proportion of patients. So who should have repeat testing? Patients who are at high risk for acquiring HIV, so a patient or partner who has injection drug use, who exchanged sex for drugs or money, an HIV partner, or having a new sex partner during the pregnancy, or if they have a suspected or diagnosed sexually transmitted infection during pregnancy. Also, if they reside in a jurisdiction of high incidence of HIV, or if they have signs or symptoms of acute HIV. So this slide actually shows the different states that have requirements for HIV. And if you can see, based on the color coding, that not all states are equal in this. The light blue shows where there are statutes for HIV testing during pregnancy, but not specific to the third trimester, to labor and delivery, or for newborns. The darker blue states, so these states have statutes for HIV testing during labor and delivery, but not specific to third trimester or for newborns. The blue-green colored states, so Illinois is one of those where I practice. The statutes for HIV testing are including third trimester testing and for newborns. The purple color states have statutes for HIV testing during the third trimester, but it's not specific to newborns. The orange colored states have statutes for HIV testing for newborns, but not specific to the third trimester. And the other non-colored states have no statutes for HIV testing during pregnancy. So how important is this? The importance of partner testing is because, of course, exposure to HIV through a sexual partner who's unaware of his HIV status places the woman and the fetus at risk. Surveys have shown that less than 21% of women were aware of their partner's HIV status during that pregnancy. Perceptions of risk, like the safety to the fetus or partner fidelity, or logistical considerations like access to testing or costs, as well as a history of testing, contribute to desiring or declining HIV testing. So what should be the next step in HIV testing for Cynthia? So the answer to this question is actually C. We should repeat testing with an antigen-antibody combination immunoassay capable of detecting HIV-1 antibodies, HIV-2 antibodies, and the HIV-1 P24 antigen. Given the fact that Cynthia has a partner that is positive for HIV, she is at high risk for acquisition of HIV during her pregnancy. So A, no additional testing needed at this time is not correct. B is not correct because the test may be a false negative because early in infection prior to HIV seroconversion, the antigen antibody screen may be negative, but the HIV RNA assay will be positive. And so that makes B incorrect. D, monitor Cynthia and screen her for HIV every 6 months is not correct, given her risk for acquisition during the pregnancy. And E, if you're not sure, now you know the answer is C. So negative, false negative. Discordant HIV results can be seen. So a woman may receive a negative result during a window period of up to 15 days post-infection when using the combined antigen antibody immunoassay, and up to 28 days with other assays. However, during this time, she's very viremic with a high risk of perinatal transmission to the child. So early in HIV infection, prior to HIV seroconversion, the antigen antibody screen will be negative, and the HIV viral load or HIV RNA assay will be positive. So what are the HIV testing guideline recommendations? Guidelines currently recommend that your initial testing with the immunoassay should detect HIV-1 antibodies, HIV-2 antibodies, and HIV-1 P24 antigen. This is what we refer to as an antigen antibody combination immunoassay. Individuals with a reactive antigen antibody combination immunoassay should be further tested with an HIV-1, HIV-2 antibody differentiation assay. This is what we refer to as a supplemental testing. Individuals with a reactive antigen antibody combination immunoassay and a non-reactive differentiation test should be tested with an FDA-approved plasma HIV RNA assay, which looks at the HIV viral load to establish a diagnosis of HIV infection. So what maternal viral load indicates a cesarean delivery for a woman to prevent perinatal HIV transmission during pregnancy? And the answer in this situation is C, greater than 1,000 copies. And this has been seen in numerous studies that have been done during the antiretroviral therapy era. So what are factors that are associated with high risk of perinatal HIV transmission? It includes not receiving prenatal care, having received no antepartum antiretroviral therapy or only intrapartum antiretroviral therapy, to have initiated antiretroviral therapy late in the pregnancy, so during the 2nd or 3rd trimester, having received a diagnosis of acute HIV during the pregnancy or in labor, and or having an HIV viral load that is greater than 50 copies close to the time of delivery, including those who received antiretroviral therapy and did not have sustained viral suppression. So let's take a look back at our case. Repeat testing confirms that Cynthia is HIV positive. Her viral load is 22,000 copies. She is initiated on antiretroviral therapy. Baby boy Jackson is born at 36 weeks by cesarean section, weighing 2.9 kilograms. Cynthia's viral load at delivery is 1,200 copies. She is counseled not to breastfeed. So because Jackson was exposed perinatally, when should virologic testing be done? So how do we test infants for HIV? The virologic diagnostic testing is a little bit different in infants, and the assays directly detect HIV. HIV antibody tests should not be used. Plasma HIV RNA or cell-associated HIV DNA nucleic acid tests are what's recommended. We recommend them at birth, at 14 to 21 days, at 1 to 2 months, or at 4 to 6 months. A positive virologic test should be confirmed as soon as possible by repeat virologic testing. False positives can occur with both RNA and DNA assays. So back to our case with Jackson, at birth, his PCR testing is negative. He is then initiated on presumptive therapy prophylaxis, given that he is high risk. At 2 weeks, Jackson's PCR is now positive, and he is referred to specialty care after being started on or continued on zidovudine, lamivudine, and nevirapine. He has HLA-B5701 testing done, and the result is negative. He is scheduled for an appointment with infectious disease. Hello, Cynthia. I'm Dr. Aziz. Dr. Sims referred Jackson to me. I'm an infectious disease specialist, and my focus is on children with HIV.
Hi, Dr. Aziz. I'm so glad to be talking to you. I'm really worried about Jackson's condition. When he tested HIV negative when he was born, I was so relieved. But then to have that change is very confusing. Was it a bad test?
I completely understand. It's really confusing right now. Sometimes babies have a negative test in the first week of life, and then they have a positive test later. That's why we test them pretty often to make sure. This is called a late or intrapartum infection. And sometimes the test just works better a couple weeks after the initial test.
Well, if it changed once, is there a chance he could become HIV negative again?
That's unlikely. We typically, once the test is positive, it's going to stay positive for the rest of their life. In the meantime, we should just keep treating him with the medication.
I'm trying not to overreact, but he's such a little baby and it's hard not to worry. As a first-time mom, it's tough not to jump to the worst conclusions. Does he have to be on medicine now? Can it wait until he gets older and stronger?
It's important long-term that we treat him for HIV so that it doesn't cause long-term damage. So at each stage of a baby's life, there's different medications that are used. Some become more appropriate as they gain weight and they grow and they get older. The medicine that he's currently on is actually the best one for the first 2 weeks of life. But as he gets older in the next couple of weeks, he'll be ready for the next step. So I'm going to prescribe a combination of drugs. The combination is abacavir, lamivudine, and lopinavir/ritonavir. We'll continue to monitor not only his virus level, but also any side effects that might emerge.
Okay, thank you, doctor.
So why do we treat for HIV? There is biologic aging in children who are infected with HIV perinatally. So the persistence of HIV causes chronic immune activation. This is likely a key determinant in premature senescence pathways. The lifespan of HIV-infected children is not yet comparable to those that are uninfected. Premature aging exposes children to a higher risk of acquiring or developing age-related chronic renal issues, cardiovascular disease, metabolic complications, cerebrovascular diseases, and malignancies. Antiretroviral therapy can improve survival and the quality of life. So what are the benefits of early treatment initiation? This was shown early in the SHARE trial, the Children with HIV Early Antiretroviral Therapy trial, which demonstrated a 76% reduction in early mortality and a 75% reduction in HIV progression among treated infants 6 to 12 weeks, compared to delaying treatment until infants met clinical or immune criteria. The SHARE substudy also found significantly better gross motor and neurodevelopmental profiles compared to deferred treatment. This was associated with improved viral suppression and reduced size of viral reservoirs. So the DHHS has preferred regimens that we can give to our infants that are classified by age, weight, and drug class. So if you take a look at this table, from birth to less than 14 days of age, when you have an integrase inhibitor-based regimen, it is recommended to have 2 NRTIs plus Dolutegravir. If you look at the NNRTI-based regimens, it's recommended to have 2 NRTIs plus nevirapine. And the choice between those two is based on availability of the drugs, the ease of delivery of the drug to the infant, and patient preference. If you look at ages greater than 14 days and greater than 2 kilos to less than 2 kilos, your choices are 2 NRTIs plus Dolutegravir, or a PI-based regimen of 2 NRTIs plus lopinavir/ritonavir. When you look at ages greater than 4 weeks and greater than 3 kilos to 6 years of age, you then have the option of 2 NRTIs plus Dolutegravir. And at age 6 years and greater than 25 kilos, you have the option of 2 NRTIs plus Bictegravir. DHHS also talks about the preferred dual NRTI backbone options that are in use for combination with other drugs. So DHHS has preferred recommendations on dual NRTI backbone options for use in combination with other drugs. This is delineated by the age of the patient in terms of what options are there. So for neonates that are birthed to age less than 1 month, you can do zidovudine plus lamivudine or emtricitabine. Infants and children greater than 1 month to less than 6 years of age have the option of using abacavir plus lamivudine or emtricitabine, or zidovudine plus lamivudine and emtricitabine. Children and adolescents greater than 6 years of age can use abacavir plus lamivudine or emtricitabine. And they can use FTC and TAF if their weight is greater than 25 kilos and they're receiving a regimen that contains an integrase inhibitor or an NNRTI. Adolescents aged greater than 12 years can usually follow the adult and adolescent antiretroviral therapy guidelines. So I wanted to spend some time today talking about the importance of making sure that Jackson is taking all of his medication every day. It's something that's extremely important, but it's also the hardest part when you have a chronic disease.
So what can happen if he doesn't take his medication every day? Is it something bad?
Well, Jackson could become resistant to the medication. And what that means is it might not work anymore against the HIV. Unfortunately, what happens is if you're resistant to medication, it means that we don't have as many treatment options because he might not be able to take the other medications either because of his age.
Okay, I will do my best.
Okay, great. So my nurse is going to spend some time with you and give you some information and some tricks of the trade for remembering to giving his medication every day. She'll also give you a number to call with any questions. And there's always someone that's on call to help you and support you if there's any issues until you get into a routine.
Okay, good. That kind of support will help me.
So on each visit, we'll check Jackson's viral load in order to measure how effective the medication is and how good of a job he's doing in taking the medicine. The testing will be more frequent in the beginning, but as things become more usual and you get used to things, we won't have to do it as often. I would like to have you test Jackson's blood work in 2 weeks to make sure that everything is going on track. And we'll connect over telehealth so you don't have to keep bringing him back in.
Okay, thank you so much, Dr. Aziz. This helps. I would prefer not to take him out more than I have to.
So how do we counsel our patients when it comes to treatment adherence? Strategies to maximize adherence should be discussed before and at initiation of antiretroviral therapy, and again before changing regimens. Ongoing assessment of adherence and promotion of adherence at every visit is essential. In addition to viral load monitoring, at least one other method of measuring the adherence should be used. Once daily regimens and regimens with a low pill burden should be prescribed whenever possible. So what can disrupt this adherence? Well, dependence on others for medication administration can cause disruption in adherence. Adult forgetfulness, changes in routines, and children's objectives to medication can also disrupt adherence. Social and health issues within a family, such as substance use, poor physical or mental health, unstable housing, poverty, violence, involvement in the criminal justice system, and limited social support, all can be barriers to care as well. So back to our case with Jackson. Jackson does well on the combination of abacavir, lamivudine, and lopinavir/ritonavir. As he ages and begins attending school, Cynthia struggles with keeping him adherent to his medication. His most recent viral load is less than 50 copies. Hi, Cynthia. How are you and Jackson doing today?
We're good, Dr. Aziz. Jackson started school and he's adjusting to going to school full time. He actually loves riding the bus.
Oh, that's so adorable. That's great. Well, thanks for getting his blood drawn. It looks like, looking at his blood work, that his virus level and his CD4 count are right where they're supposed to be. How's he doing overall?
In general, fine, but over the last 2 or 3 weeks, he's really had some GI issues, mostly diarrhea, but he complains that his stomach hurts too. He's been a real handful since he doesn't want to take his medicine because he says it tastes funny. And now adding diarrhea and nausea on top, getting to even take his meds is a struggle every day.
Well, one of the medications that he's currently taking has been linked to GI side effects. Now that he's older and meets all the weight requirements, it might make sense to do what's called a stable switch.
What does a stable switch mean?
So, his virus level is doing so great and he's overall doing so well. There are data that show that in this case, if we switch medications that are, to other medicines that are effective, it won't disrupt his virus level or his CD4 count.
Do you recommend that?
So, what would be your next step for Jackson? So, for this question, there's really no right or wrong answer except for A. It's clear that in this situation that his drugs may be causing his GI side effects and it would be appropriate to switch him. So let's talk about fixed dose Bictegravir, FTC, and tenofovir alafenamide in children with HIV. There's a recent study that came out that showed that in virologically suppressed children, which had an N of 100, on a stable antiretroviral therapy regimen for at least 6 months, the people who were included in this were greater than 6 years and 25 kilos. They had HIV viral loads less than 50 and CD4 counts greater than 200. And when they looked at this, all the participants had viral suppression at week 24, and 98% of them had viral suppression at week 48. It was noted to be well tolerated with only one discontinuation due to adverse events, and no participants had treatment emergent resistance. And what about Dolutegravir? There have been multiple studies that have looked at Dolutegravir in older children through the Impact 1093 studies. But more recently, the Odyssey study looked at simplifying the Dolutegravir dosing for children with HIV greater than 20 kilos. This was an open label, multi-center, randomizing non-inferiority phase 2/3 trial that evaluated the efficacy and safety of Dolutegravir plus 2 NRTIs versus standard of care over 96 weeks in 700 children with HIV. Dolutegravir 30 milligram dispersible tablets provided similar exposure to the 50 milligram coated tablets. This can be used in children that are unable to swallow tablets. So this slide just includes information on formulations of integrase inhibitors for treatment in children with HIV greater than 6 years. They have some advantages and disadvantages depending on the integrase inhibitor. So if you look at Bictegravir, it has once daily administration. You can give it with or without food, and it's available in fixed dose combination tablets. However, the fixed dose combination is not recommended if there's hepatic impairment or if there's a creatinine clearance less than 30, and it should not be administered with rifampin or dofetilide. Dolutegravir has once daily administration as well, can be given with food, also is available in fixed drug combinations. Single agent pills are available in several doses and are very small in size, which is different than Bictegravir. It's also available as dispersible tablets for suspension, which may provide ease of delivery in some children. However, there are some disadvantages in the drug-drug interactions with Epaverins, with some protease inhibitors, and rifampin necessitating twice daily dosing. And it can be associated with CNS side effects, particularly sleep disturbances, although these are very rare. If you look at Elvitegravir, there's once daily administration, and it's available in fixed dose combination tablets. However, among the integrase inhibitors, Elvitegravir has the lowest barrier to the development of resistance. It's co-administered with cobicistat, which has a potential for multiple drug-drug interactions because, as you know, cobicistat is metabolized by the CYP3A4 hepatic enzymes. Cobicistat may result in an increased serum creatinine, but this is a false elevation because there's normal glomerular clearance, so it may cause some confusion with the kidney testing. Raltegravir. So this drug has its advantages. You can give it with food. It's available in tablets, chewable tablets, as well as a powder formulation. The chewable tablets can be crushed and mixed with liquids. The powder formulation can cause some difficulty in mixing. Once daily administration with Dolutegravir can be used for treatment naive or virologically suppressed children that weigh over 40 kilos. The disadvantages of Dolutegravir include the potential for rare systemic allergic reactions or hepatitis. And then the powder formulation requires a multi-step preparation, as I mentioned before, administration, and the caregiver must be taught how to properly prepare this formulation. So we can talk about the SMART goals. So these are specific, measurable, attainable, relevant, and timely goals. And so what we'd like to do is employ HIV screening in pregnant women during pregnancy, including the third trimester, to be proactive about assessing the risk of perinatal transmission, to screen infants at risk for HIV infection at birth at 14 to 21 days, 1 to 2 months, and 4 to 6 months to guide decision-making, to follow guidelines for the recommendation for treatment of children with HIV based on age and weight, and to conduct ongoing monitoring and counseling of patients and caregivers to optimize treatment adherence. So today's CMEO briefcase is part of a 3-part series of case-based activities that can be found on the Infectious Disease Hub at CMEOutfitters.com. I hope you'll check out the other 2 activities in the series. The Infectious Diseases Hub has these activities and many other activities on HIV. CME Outfitters also has an HIV patient education hub with a number of excellent resources to share with your patients. Thank you for joining me today. Don't forget to complete the post-test and evaluation. As a reminder, this activity is also available for ABIM MOC credit. Stay safe and thank you again for providing the best care for your patients.